Good morning, good afternoon, or good evening, everybody. Thank you for joining us for this session on unfinished priorities for health and health systems for migrants and refugees. My name is Rima Afifi, and I am a professor in the College of Public Health at the University of Iowa in Iowa City in the United States of America. The way that this session is going to proceed is that I will be introducing each of the speakers, followed by the pre-recorded session from that speaker, and then I will introduce the next speaker. We will be seeing the four speakers' presentations, one after the other, and we will leave the questions for after everybody has gone through their, after you've seen all the pre-recorded sessions. You can feel free to write your questions in the sort of the question and answer panel, and I will then, after we're finished seeing the presentations, ask the questions of the presenters. If you have a question that's directed particularly at a specific presenter, if you would actually start that question off or let us know that is who you want to answer that question. All right, so with that, I will go ahead and start. And just to let you know that at this point, we only have two of our presenters for the live Q&A, and two are not here for the live Q&A, but they may join eventually. Our first presenter is Catherine Nakide. Catherine is a program coordinator with the Center for Health and Social Economic Improvement. Catherine's wide-ranging background includes experience as a public health and international development practitioner, researcher, and educator. And since 2014, she's worked on multiple research projects spanning the maternal, newborn, and child health continuum of care, quality improvement, regulation, urban and refugee populations, as well as youth livelihoods. And Catherine's presentation is entitled Determinants for Utilization of Healthcare Services, a case of urban refugee adolescents in Kampala's informal settlements. Thank you.
Hello, my name is Catherine Nakide, and I'm presenting from Kampala in Uganda. I am talking about a study that aimed to investigate the determinants of utilization of health services by refugee adolescents in Kampala's informal settlement. This study adopted Anderson's model for healthcare utilization, which proposes that healthcare utilization is based on a few factors that could be grouped into societal, individual, and healthcare system factors. This study was done because there's not much information about utilization of healthcare services by adolescents in who have a refugee background or even in developed countries. The study took a cross-sectional design and a mixed methods approach, and it selected participants between 10 to 24 years in Kampala's informal settlements of Kisenyi 1, 2, 3, and Mengo. In terms of analysis, we utilized SPSS version 20 as the software for quantitative analysis, and qualitative data was analyzed thematically and organized using Atlas TI7. So Anderson's model also groups these factors that affect healthcare utilization under predisposing factors, enabling resources, and need factors. For this study, when it came to predisposing factors, majority of the participants were aged 15 to 24, females, and under the ordinary level of education. Enabling resources, which may hinder or promote the utilization of services. Majority of the participants had access to health information, and they reported to be in close proximity with a healthcare facility. Others had parental support in relation to their healthcare needs. The only need factor that was studied for this that was investigated for this study was self-rated health, which was reported to be between good and average for the majority of the participants. Utilization of healthcare services was found to be rare, and 60% of the participants confirmed this. And the reason this was so was confirmed in our qualitative results, which showed that majority of the participants failed to go for services because of language barrier, because of the fees they need to pay for the services since they preferred private facilities, and the healthcare worker attitudes that usually turn them off from going back after they have sought services at any one point in time. At the bivariate level, only access to health information, facility preference, and satisfaction with services that were received the previous time the adolescent may have gone to a facility were found significant for trying to access services and using them by adolescents. However, after logistic regression, only access to healthcare information was found to be significant, and for those that had access to healthcare information, the odds for utilization were 0.5 times higher compared to those who did not have. In terms of the qualitative findings, a few key themes were found, including the role of schools in health promotion. Schools were found to be an avenue that is important for providing health services for these adolescents in this population. Then the other issue that came up was the quality of care that may be provided by a service provider at any one point in time, which could determine whether an adolescent will come back or not. The other issue that was important for these adolescents was the preference for private healthcare facilities, which require them to pay for services. However, this is not very new because public facilities usually lack drugs and equipment, and will send their users away to go and utilize services from somewhere else. So this wasn't a surprising finding. In conclusion, access to health information is very important, but information that is provided at schools actually reaches adolescents much more than what is provided at healthcare facilities, for example. So schools need to be utilized for providing information and any other services that could help adolescents overcome their challenges, their day-to-day challenges. And in light of that, the recommendation is to arm schools with the information and the capacity they need to provide services for adolescents. Then the other recommendation is for research. More research needs to be done around this topic, especially because this study did not go so in-depth to explore the other issues that adolescents face that could hinder them from utilizing services. And lastly, private healthcare facilities in Uganda need to be encouraged to take up the adolescent-friendly model, which is the preferred model for providing services for adolescents, but majority of the facilities that were examined in this study were not utilizing this model. Thank you very much.
Thanks. Thank you to Catherine for that very interesting presentation. Our next presentation will be by Jargal Batbatar. And Jargal is in the Department of Health Policy and Management in the School of Public Health at the Mongolian National University of Medical Sciences in Mongolia, as well as with the Faculty of Economy and Business Sciences at the University of Sannio in Benevento, Italy. And her presentation is entitled Quality of Life Among the Refugee Population in Finland.
Hello everyone, I'm happy to present our research results titled Quality of Life Among the Refugee Population in Finland. In 2015, Finland received over 32,000 asylum applications, which was the fourth highest number of refugees per capita during the 2015 mass migration to Europe, behind Hungary, Austria, and Sweden. In Finland, asylum seekers are not granted the same entitlements for health services as the Finnish residents. Thus, individuals without a residence permit, such as asylum seekers, don't have access to the full range of public health services. And also, healthcare services for asylum seekers are funded and delivered by migration authorities, and the capacity was for low number of asylum seekers. After the influx of asylum seekers, Finnish relatively good welfare and health systems were tested, and the further policy implementations to meet the needs of asylum seekers are required. Aim of this study was to assess the subjective quality of life among the refugee population after their resettlement in eastern Finland to unravel the contributing factors and their interactions to shape their health and well-being for the further policy. The data in this study was obtained from Working Package 5, nationwide PROMEC project, which was targeted asylum seekers and refugees who came to Finland since 2015. This study included 161 granted asylum seekers, quota refugees in eastern Finland, and WHO's quality of life brief standard questionnaires in Arabic and English language were used. And the data collection process was done between May and July of 2017. And the statistical analysis was structural equation modeling. The general characteristics of the participants are presented in this table. Most participants were male, aged between 18 and 39 years old. 58% of them were from Syria, and about 60% of them were married and had lower secondary education. The majority of them were students and in vocational or work training, whereas only 1.2% were in full-time work, and thus 67% of the respondents had less than 15,000 euros of household income in the year prior to the study. Approximately 75% of the participants responded that they were satisfied with their health, whereas only 78% of them rated their quality of life in Finland was good. This is the statistical model to test the precedents, antecedents, and their interaction to shape the subjective quality of life of the refugee population in Finland. Basically, WHO's quality of life brief tool for measuring quality of life has 4 main domains. But our baseline hypothesis was that these 4 domains can't explain fully the experience of refugee populations because most of them from conflict zones and experience of trauma and discrimination. So trauma experience before they come to Finland and discrimination experience after their coming to Finland were important to our analysis, which in turn have effect on their mental health status. So the domains trauma experience, discrimination experience, and mental health status were added to the basic model. And the model explained 94.1% of the variation in quality of life, which is a quite good predictive power. Table 2 shows the direct effects of the domains on some independent variables and dependent variable of quality of life. We can see the positive relationships between independent and dependent variables. Only the PET coefficient between age and quality of life was negative. And trauma experience had the strongest effect on mental health of migrants. And mental health status of them had the strong effect on their social relationships. Among the 4 main domains of quality of life, physical health had the strongest direct effect on quality of life. When we run multi-group analysis, only the education level had statistically significant for the discrimination and mental health relationships. Okay, now we can conclude the results of our study. The perceptions of physical health contributes the highest to the quality of life among the refugees in Finland, followed by income level, perceptions of psychological health, environment quality, age, and social relationships. Among these contributors, only each has a negative effect of on quality of life explain that the younger the age, higher the perception of quality of life. If the participants had no experience of trauma before coming to Finland and no discrimination experience after coming to Finland, they would have better mental health outcomes. So better mental health outcomes lead them to the perceptions of better physical and psychological health, environment quality, and social relationships, which in turn result in perception of better quality of life. Respondents who have higher education tend to experience less discrimination and better mental health outcomes. So the policy implications, the empirically based practice would help to create a refugee-friendly society in Finland, and policy and practice need to address the refugees' both physical and mental health and their needs, and the refugees will benefit from the culture-sensitive and well-prepared practices to address their language ability, education attainment, employment, and economic well-being. Thank you for your attention.
Thank you to Ankjargal for that very interesting presentation. Our next presentation is by Filippa Mladovsky. Filippa is an assistant professor in international development at the London School of Economics and Political Science. Her research interests include universal healthcare coverage, health financing, equity and access to healthcare, migrant and refugee health, and the impact of austerity on health systems. As well as conducting academic research and teaching, she has worked as a policy analyst for the World Health Organization and for the European Observatory on Health Systems and Policies. Filippa completed her PhD in social policy at the LSE, focusing on sociological perspectives on health financing in Senegal. And Filippa's presentation is entitled, "What is the impact of securitization on migrant mental health services? Evidence from the English health system."
What is the impact of securitization on migrant mental health services? Evidence from the English health system. Refugee mental health prevalence has been estimated in an international literature review to be mental ill health prevalence to be around 9 to 36% for PTSD, for post-traumatic stress disorder, compared to only 1 to 2% in host populations. Refugees who have lived in a host country for more than 5 years tend to display a broader range of mental health problems, showing high rates of depressive and anxiety disorders than the host population. So this suggests that something happens during the first 5 years in a country to a refugee that actually worsens their mental ill health. So this can be attributed to highly inadequate refugee mental health policies and services. So we know that the government actively creates or exacerbates a mental health burden in refugees through so-called policies of immigration deterrence, which are openly called hostile environment policies in the UK, which seek to stop migrants and refugees from coming to the country. Having created a increased mental health burden in refugees through these policies, such as long periods in immigration detention, insecure housing, no opportunities to work whilst in the asylum system, the government then spends public money on funding highly specialised refugee mental health services in the community. These are not universally provided, so there is what's called a postcode lottery. Depending on where you live determines your access to these services, but nevertheless the government is spending money on treating these services. There's incoherence and inconsistency in policy. So, for example, migrant health policies rarely or never mention the hostile environment as a risk factor, and refugees and migrants are generally absent from Black and minority ethnic mental health policies, which is another area of incoherence. Common explanations for this policy incoherence and policy failure include technical explanations, social explanations, and political explanations, including a racist or xenophobic asylum system, immigration system, and also NHS. However, after years of making these points, there hasn't really been much progress, or there's been even a reversal or a deterioration in this area in terms of the well-being, the mental well-being of refugees and policies in this area. So, which leads to the question of is there an underlying rationality that might explain this policy dysfunction, that might link all of these explanations, that actually serves a purpose? So does this dysfunction serve a purpose? In this study, I draw on the theories of Bigot and his theories of the securitization of migration as the governmentality of unease, with the idea that immigration is securitized as part of a general structural unease, characteristic of risk societies, framed by neoliberal discourses in which freedom is always associated at its limits with danger and security or insecurity. He talks about a variety of securitization practices where the aim is to master a chaotic future with minimalist management, focusing only on risky groups, with the rest of the population being overlooked in terms of this management. There's a use of population data and statistics to create and recreate targets through a process of anticipating risk profiles and a process of pre-criminalization. The legitimacy of professionals in charge of management of risk and fear is grounded in continuous everyday administrative practices, which include coercion, protection, pacification, control, surveillance, and others. Security experts, including the military, police, health experts, and economists, are in continuous competition with each other for resources, legitimacy, and autonomy over their fields of knowledge, producing a shifting set of truths that are, rather than any definitive understanding of a given threat. So, in my study, I conducted ethnographic fieldwork in 2015 and 2016, and then a series of interviews also with refugee mental health services in 2019 and 2020. The interviews and field notes were analysed thematically and also supplemented with analysis of policy documents and a review of peer-reviewed literature. Many securitization practices are evident in the interviews, particularly relating to that particularly become apparent in policies resulting from austerity following the 2008 financial crisis, where I argue that austerity reduced mental health providers' ability to resist this governmentality of unease. So we see category creation and the focus only on risky groups. So refugees with PTSD are considered only a risk to themselves and therefore represent minimal risks to society. If refugees in trauma services are considered to pose a risk to society, they were sorted into categories and referred to more coercive services. Refugees with psychosis referred to early intervention for the prevention of psychosis or inpatient care, which were much better funded than the PTSD services, which were experiencing very serious cuts, which I'll talk about more in a minute. Refugees that were at risk of Islamic radicalization were referred to anti-radicalization programs, and refugees whose asylum application was refused were treated in detention. So prior to austerity, refugee trauma services were able to provide holistic care, and refugees were provided with support for housing and employment. But after austerity, this was cut and the number of therapy sessions were greatly cut. There's a continuous competition for resources. Following austerity, therapists are no longer able to collaborate with each other due to this high levels of competition. There is a great deal of information gathering and sorting, also a shifting set of truths produced by the institutions and experts, where services, for example, were not based on clinical evidence, and the cuts often seemed arbitrary. So in conclusion, austerity has extended the governmentality of unease to refugee mental health services treating PTSD. Following cuts, these services are increasingly characterised by securitization, and this contributes to the apparent dysfunction of refugee mental health policy, as well as poor quality and inequitable care. Thank you.
Thank you to Philippa for that very interesting presentation. I do want to encourage attendees to enter any of the questions that they have in the live Q&A box, so that we can have an interactive session once this final presentation is completed. Our final presentation for today will be given by Victoria Schoen. Victoria is a program analyst at the Duke Global Health Innovation Center and Innovations in Healthcare. She provides research, program, and implementation support to a diverse portfolio of global health projects focused on innovation, policy, and health system strengthening. Victoria is passionate about the intersection of health and the humanities and narrative medicine, and strongly believes that understanding the lived experiences of those closest to the problem is essential to developing equitable and sustainable solutions. Victoria received a BS in biology and a BA in global health from Duke University. And Victoria will be speaking today on leaving no one behind in East Africa, leveraging policy to ensure continuity of care for migrant populations.
Hi, my name is Victoria Schoen, and I work for the Duke Global Health Institute, and I'll be presenting today on the Regional Action Through Data, or RAD project, about how we can leverage policy to really ensure continuity of care for vulnerable migrant populations in East Africa. So the Regional Action Through Data project originated from a co-creation workshop hosted by USAID with the goal of improving continuity of care for cross-border settings to promote improved health outcomes through enhanced data use as well as innovative e-health technology. So the RAD consortium consists of the Duke Global Health Institute, which I'm representing today, as well as GEMBI Health Systems and Broadreach Healthcare. And we work with EGAD and ECOWAS, which are regional economic communities in East and West Africa, respectively. And so through this project, we work on 3 different levels: the regional level through Broadreach's work, the patient-provider level, so more on the individual level, which GEMBI Health Systems is doing. And finally, at the Duke Global Health Innovation Center, we work on the policy level. So looking at how we can apply policy solutions to create a conducive environment for innovation on the other levels, as well as support regional harmonization of data sharing policies to improve equitable care in both East and West Africa. So my presentation today focuses on how cross-border mobile populations are better able to access care. So cross-border mobile populations face really unique barriers to accessing healthcare. These populations are especially vulnerable due to their transient nature. So these populations include migrant workers, sex workers, refugees, and other populations that consistently travel outside their countries of origin or between 2 or more countries. So often these populations are created by the intersection of very complex social, economic, and political forces. So for example, migrant workers may choose that line of work as a result of economic uncertainty in their home country, or sex workers, their vulnerability may be compounded by social stigma, as well as economic risks that they put themselves at through their work. And refugees can emerge from political crisis or economic instability in a region or a country. So these populations especially face difficulty accessing healthcare when they're outside of their countries of origin. they also face a lack of continuity of care. Because they are transient and moving around, may not have one home or one point of care that they regularly access, it can be difficult for them to experience continuity of care and to see providers who are up to date on their medical history and who have access to their records. So this inadequate quality of data that can be inconsistent between health centers or points of care, as well as the unreliability of those medical records, can impact their ability to really access quality care. And finally, these vulnerable populations are really susceptible to the misuse of their personal data. So our work focuses mainly on CBMPs in the EGAD region. So EGAD is the Intergovernmental Authority on Development, a regional economic community in the East and Horn of Africa. So CBMPs in this region face all the challenges that I listed before, but in addition to that, the member states themselves face additional challenges in ensuring health outcomes for their whole population because they're often unable to effectively monitor the health of these populations that are mobile or transit and that aren't accessing that care regularly. And one important aspect of this impacts is it creates more challenges in the accurate and timely prediction and tracking of disease outbreaks and epidemics. So when it comes to things like contact tracing or even just understanding the prevalence of a certain disease in a region, it's really important to account for these populations as well as those established non-transient populations. And of course, this can also create challenges in then planning versus allocation and decision-making when you're lacking that data. And finally, flow of health information throughout the region can also, it might not also meet the current data privacy standards. So what we did is we focusing on the EGAD region in East Africa, we conducted a policy landscape analysis where we looked at the data sharing policies and the health policies in different member states and look at how they overlapped and how they interplay with each other. And we had three major findings from this landscape analysis, which were that there was a lack of legal or regulatory frameworks for data sharing. There were inconsistent standards and policies for data protection, and there were also inconsistent patient confidentiality and privacy laws. So based on these findings, we worked with EGAD to conduct a grid analysis where we considered different solutions that would address these gaps. So when we were performing this grid analysis and considering these solutions, we considered the potential for impact, the timeline for them, and the feasibility of carrying out these solutions within the project timeline. So based on this grid analysis, we found that the best fit solution was to develop a regional health data sharing and protection policy. So here I have a quote from a steering committee meeting that the RAD consortium held with EGAD, stating the decision to go ahead with the development of this policy. And so what we're doing now is a really iterative three-pronged process of developing this regional policy, making sure that we're taking into account in-depth research and consideration of comparable policies in other regions, feedback from key stakeholders and experts throughout sectors and throughout the region, so that we can take into account best practices, perspectives from various fields, and any expertise that we can. And then iterating on this policy based on that feedback, as well as consistently meeting with representatives from member states, getting their buy-in, getting the input and their perspective on the application of a policy in their country. So looking ahead, what we view as the way forward to ensure continuity of care for these vulnerable populations is an intersection of data sharing policies, mHealth innovations and eHealth innovations, as well as regional harmonization to ensure that we can do our best to promote equitable access to care for all populations and make sure that we leave no one behind. Thank you.
Thank you to Victoria as well for that very interesting presentation. And over the last 4 presentations, we have seen quite a large scope of exploration of the issues around migrants and refugees. So we've heard projects that talked specifically to refugees, to providers, and to policymakers, and they used multiple methods to do so. Every single one used multiple methods. And the settings were either in camps or in health centers or even at the country level. So a very interesting range of presentations around unfinished priorities for health and health systems for migrants and refugees. At this point, we have no questions in the live Q&A. I will give just a minute to add more questions if anybody would like to ask any. Seeing none, we would like to just remind you of the opportunity to contribute to reimagining health systems. If we could put the slide up. Thank you. This is an opportunity for each of us to contribute to the thinking of health systems global around how we might reimagine health systems. And there's an opportunity to go into the link and provide your thoughts and comments on how we create a world that promotes health equity and justice through reimagining health systems. Thank you for joining us today.